Hello everyone. Today we will discuss about complications of diabetes mellitus. So diabetes mellitus is a chronic metabolic disorder characterized by persistent hyperglycemia due to defects in insulin secretion or insulin action or maybe both. So the long-term exposure to hyperglycemia leads to progressive structural and functional injury to blood vessels, nerves, kidneys, retina and myocardium. Thus the diabetic complications arise from a combination of metabolic toxicity of glucose, hemodynamic changes, oxidative stress and chronic low-grade inflammation. Thus the complications are conventionally classified into acute metabolic complication and chronic complications. So what is the overview of classification? We can classify this into acute complications, chronic microvascular complication, chronic macrovascular complication and other chronic complications. So the acute complications include diabetic ketoacidosis, hyperosmolar hyperglycemic state and then hypoglycemia, typically arising due to insulin or oral hypoglycemic drugs overdose. Then chronic microvascular complications includes retinopathy, nephropathy and neuropathy. Chronic macrovascular complications include coronary artery disease, cerebral vascular disease and peripheral arterial disease. Other complications include diabetic foot, infections, gastroparesis, erectile dysfunction, musculoskeletal and dermatological disorders. What are the acute complications? So this diabetic ketoacidosis most likely occurs in type 1 diabetes mellitus, but it can also occur in insulin deficient type 2 diabetes mellitus. The core pathophysiology is absolute insulin deficiency leads to lipolysis, leads to increased ketone production, leading to metabolic acidosis. This clinical features include polyuria, vomiting, abdominal pain, Kussmaul respiration, fruity breath and coma. Hyperosmolar hyperglycemic state. So this typically occurs in elderly type 2 diabetes mellitus, wherein there will be severe hyperglycemia resulting in osmotic diuresis, resulting in dehydration, resulting in hyperosmolarity. This clinical features include extreme dehydration, confusion, seizures and coma. Hypoglycemia, insulin or sulfonylurea use. So there will be excess insulin resulting in neuroglycopenia, resulting in sweating, tremor, confusion, seizures and coma. Coming to the molecular mechanism, this can occur due to advanced glycation end products, sorbitol pathway activation or protein kinase activation and oxidative stress. So what is diabetic retinopathy? So this can occur as non-proliferative diabetic retinopathy, proliferative diabetic retinopathy and diabetic macular edema. In case of non-proliferative diabetic retinopathy, there will be microaneurysms, dot blot hemorrhages, hard exudates and cotton wool spot, often asymptomatic. In proliferative, there will be retinal ischemia and neovascularization, wherein there will be vitreous hemorrhage and retinal detachment. Diabetic macular edema, this can result in capillary leakage and macula and there will be central vision loss. Coming to diabetic nephropathy, there will be hyperfiltration due to increased glomerular filtration rate, but the clinical marker will have a normal albumin. Then there will be incident nephropathy, there will be mesangial expansion, microalbuminuria. Overt nephropathy resulting in glomerular basement membrane thickening and nodular sclerosis. There will be macroalbuminuria with greater than 300 mg per day. Advanced nephropathy resulting in glomerular sclerosis. There will be decreased GFR and end stage renal disease. Coming to diabetic neuropathy, there will be distal symmetric polyneuropathy, which likely occurs due to ischemia and sorbitol toxicity. There will be numbness, burning pain and loss of vibration sense. Autonomic neuropathy, this is due to small fiber injury, there will be gastroparesis and erectile dysfunction. Mononeuropathy, there will be ischemic nerve infection resulting in cranial nerve palsies. Radiculoplexus neuropathy resulting in macrovasculitis, there will be severe proximal pain and weakness. Macrovascular complication, coronary arteries, if it is affected, this will result in MA, angina and silent ischemia. Cerebral arteries will result in ischemic stroke and transient ischemic attacks. Peripheral arteries will result in claudication, ulcers and gangrene. Coming to diabetic foot, this will be a combination of nephropathy, ischemia and infection. In nephropathy, there will be loss of sensation which will result in unnoticed trauma. Ischemia result in PAD which will result in, that is peripheral arterial disease, which will result in poor wound healing. Infection will result in impaired immunity, results due to impaired immunity resulting in osteomyelitis and gangrene. The common infections in the skin include furunclosis or cellulitis. In genitourinary include UTI and candidiasis. Respiratory includes tuberculosis. Fungal include mycorrhizasis. Other system complications like gastrointestinal result in gastroparesis or diarrhea. Genitourinary result in erectile dysfunction, which is a component of autonomic neuropathy. Musculoskeletal result in frozen shoulder or Charcot's joint. The skin results in acanthosis nigrans. The prevention strategies for preventing the complication include tight glycemic control results in delayed microvascular disease. BP control results in slow nephropathy. Lipid lowering results in reduced CAD. Screening results in early detection. And smoking cessation reduces the vascular risk. So thank you for watching the video. Hope you have learned from this.